Hello, everybody. My name is Dr. Vince Gutierrez. I am a physical therapist out of Joliet, Illinois. You can find me at movementthinker.org. I'm on Facebook at Dr. Vince Gutierrez. You can find me at the DPT Mentors page, and you can find me at Joliet Around Town. We've already covered the subjective portion, the interaction back and forth, talking and chatting. We've covered posture and its role in your symptoms or its lack of role in your symptoms. And now we're going to cover measurements. Okay, one of the things that we measure is how strong are your legs, right? And big picture, I don't really care how strong your legs are, right? I care, does your back or the nerves coming from your back create some weaknesses in your legs that are a pattern that we can see, right? And so this is an interesting thing. Your back is like the compass that leads to the roadmap of your body. And where your symptoms are at kind of draws us to certain areas of your back. And if your symptoms match certain weaknesses, then it really draws us to areas of your back. And if those symptoms plus weaknesses match reflexes that are limited, then it really draws us to areas of your back, right? And so really what we're trying to do is figure out, are nerves irritated? Or are nerves not irritated? At least that's the first part of this check for your strength, right? And so we check your hips and your ability to bring your knee to your chest. Can you straighten your knee out against resistance? Can you pull your knee back can you pull your foot back against resistance? Can you pull your toes towards your face against resistance? Can you raise your big toe against resistance? Can you push your toes away from each other against resistance? Can you go onto your toes against resistance? And can you walk on your heels, right? Because all of these tell us something about the nerve health in your back. And if you're strong at all of these, then it doesn't really tell us much, right? It doesn't tell us that the nerves are irritated at all. That's a good thing, right? You don't want to have your nerves irritated. But if they are, you want your therapist to understand that that's what's happening, okay? The next thing that we look at is sensation. I'm going to touch you on parts of your thighs, on parts of your shin, on parts of your foot, and you're going to tell me, one, you're going to have your eyes closed so you can't see, obviously, because if you see it, then you might feel it, even though you may not have feeling there. You think you feel it. That doesn't matter. Your brain is very powerful. I don't know if you're catching that, but I'm going to have your eyes closed, and I'm going to touch different parts of your thigh, different parts of your shin, different parts of your toes, different parts of your foot. And I need you to tell me, one, does it feel the same or different, left to right? Because, again, it may take us back to a part of the spine. If your sensation is totally intact, congratulations. That's a great thing. If your sensation is not intact, well, then your therapist should be working to figure out why not. The next thing that we're going to look at is your reflex. You know, we hit your leg with a hammer. I have a video out there somewhere where I check reflexes. But we hit your leg with a hammer. Not a real hammer, but like one of those reflex hammers, right? One of those doctor hammers. Oh, Dr. Vince Gutierrez, yeah. We hit your leg with a hammer, and we hit your heel with a hammer. We check to see, does your leg bounce like it should? Or is there no bounce? Or is there too much bounce? When the therapist or physician or nurse practitioner is doing this to you, very rarely do people explain what we're doing anymore. And so I try to tell patients, I'm just looking at the bounce. And some bounce is good, no bounce is not so good, and a lot of bounce may not be good. And that's it, right? There's nothing to be afraid of, because if it's not good, we still don't know what's going on yet, and we don't know if it's fixable, and we don't even know if that's your normal, because it could be no bounce is your normal. It could be a lot of bounce is your normal. And so we're trying to piece everything together. What really gives us clues is if you might have a lot of bounce on one side and no bounce on another side, well, now we may have something to work with. But if both bounces are the same, we don't have much information. We have information that they're the same. That's about it. It's just data at this point. One of the other things that we look at is something called dural signs, okay, or neurodynamic testing. Somebody coached me on that before. Thanks, John Ware. Coached me to make sure that I watch my terminology. And so neurodynamic testing. And what we're looking for is when we move your nerves, how do you respond? You either respond, ha ha, no, thank you. And I've had that reaction. That's when it came right back to me immediately when I did that. Eyes bugging out of face, and all I did was move his foot a little bit. And so you can get that response, or you can get no response. I can move your nerves like completely, fully, put your foot behind your head, and there's absolutely no response. So All we're testing is how much do your nerves like to be moved and how irritable are they when they move. Now, there's some other testing that I tend to do that I notice other therapists don't do, and I don't know where I learned this. I'm sure I read it in a research article somewhere, but it's single leg stance. And I like to use single leg stance as a method of seeing how quickly and how well the brain is communicating with the body and the body with the brain in order to correct balance. And I read the stat somewhere. I don't have the exact journal somewhere. If there's a therapist out there that knows where this came from, can you cite it? So here we go. I have the patient stand on one foot with their eyes open. Test to see how long they can stand. Stand on your other foot with your eyes open. Somewhere I read that if there's a 20% difference between eyes open left and eyes open right, there is impaired communication between brain and body, and one article used that to try to determine core stability. Big bucket term, don't even worry about it. We'll just talk about communication, right? Communication means more to me than core stability. The other test is one leg, eyes closed, single leg stance, versus other leg, eyes closed, single leg stance. Now, mind you, don't try this at home, okay? Because I don't know what your balance is like. And if your balance sucks, pardon the language, if your balance sucks and you fall, don't blame me, right? This should be done under the supervision of somebody who's actually watching you to make sure that you don't fall over. Because if your balance sucks, don't test it on your own, right? Don't push yourself to that limit where you're going to fall. I've heard some patients say, oh, I was told I should stand on my foot when I was watching this video on YouTube. And I tried it and I fell. I'm shocked, right? Don't just listen to what people have to say on YouTube. But my stuff is good. Nah, never mind. Anyway, so if there is a 50% difference between eyes open and eyes closed, test it under the supervision of somebody who's a medical professional, please. If there's a 50% difference, then that also tells us that there may be impaired coordination or impaired communication between the brain and the body. These are all baselines that we're looking at to determine whether or not we can change these through interventions, through physical therapy treatments, to see how well it affects these symptoms and baseline markers that we're using. Everybody, thanks for watching. Have a good day.